Donc nous enchaînons.
So we're going to carry on now with the debate on public health, prevention and education, a European challenge. Andrea Amon, Antoine Flau, Olivier Véran, Olivier Mariotte. Would you like to come up to the stage, please? So Olivier Mariotte will be moderating.
C'est très bien. Bien.
So we're going to start the debate straight away. I think there's something that's important that needs to be pointed out. We've got half an hour to talk about the public health policy in the European Union. So we've only got half an hour, so we can't go beyond that. So we need to focus on something rather symbolic that we've already talked a lot about. That is the subject of vaccination, because that means that we can cover all of the challenges that characterize public health. Something that's important is that with the increase in populism in Europe, at the moment, there's this constant mistrust that we're seeing. Maria Gabrielle, yesterday, she said that there was a real campaign focusing on fake news about vaccination. And when we look at the figures that characterize vaccination in European countries, let's take the PHPV papillomavirus, human papillomavirus vaccination. France is not vaccinating because when you look at the cover in France, it's only 20%. So the French are the French, but the Portuguese are at 87% in terms of vaccination cover. 85% in Brittany, over 70% in Italy, and Germany, they're like us, 31%, 20%. It's the same thing. If we look at the vaccination policies that we have in countries where there is extensive vaccination with obligatory vaccination or not, if we come back to the human papillomavirus, there are some countries where boys are vaccinated, others where they're not. No, we need to wonder about how we can mobilize people for this kind of vaccination. Maybe we need to look at national representation and get them doing something about it. So that was just to set the scene for public health policies in Europe. Now let's take three main areas: operational, political, and another challenge, economic. But I'm going to hand over straight away to Andrea to find out what she thinks about this issue, this heterogeneity in terms of national campaigns. We don't seem to have a common pot or a coherence. What do you think? Is it something that has to be built, or is it something that has to be moderated? Thank you very
much. Topic. Because it's one of, together with antimicrobial resistance, one of our main topics. Why? Because vaccination and antibiotics are the two medical interventions that brought infectious diseases down, and both are endangered now. Antibiotics because we use them too much, and vaccinations, as you said, because we use them not enough. In my view, vaccines have become the victims of their success, because when I grew up, almost everybody knew someone who suffered the sequelae from polio. Now, since 2002, there hasn't been a case of polio in the EU. So the disease is gone, and people don't know what it's like to have polio. So why should they vaccinate? This goes ahead in conjunction with a declining trust in science, with new ways how this distrust can be communicated with the social media. And so in many EU countries, vaccination programs face now really challenges. Now you spoke about the heterogeneity. Immunization programs are part of health systems, and they are the competence of the member states. So as we have been discussing the whole day yesterday, these health systems are diverse. And that's no wonder that the vaccination programs are also diverse. The question is, does it help or does it hurt? And I would say both. There are certain elements where it's not helping, and these elements are picked out by those who want to create distrust in vaccines, looking at the different schedules, saying, well, the evidence base cannot be so good if there are these different outcomes. On the other hand, vaccination is something very personal also. And the culture in the EU, although we are one EU, is different. So what works in one country doesn't work in another country. So there has to be a certain diversity. And I can come back on certain examples later, how we work with these.
Antoine, par rapport à cette...
Antoine, in relation to this diversity that we have to deal with, what are the tools that we can develop? What's already been developed? And what's going to help with the mobilization of policies, politicians, and stakeholders for vaccination, for example? We can't have any results on the population. We don't have mobilization. Yes, I think we have to see things on a case-by-case basis, a vaccine-by-vaccine basis, a disease-by-disease basis. If we look at measles, for example, we need to reach 95% cover to be efficient. In other words, to make sure that measles doesn't emerge again, there's no outbreak. Now, you need to have buy-in to the policy and strategy. So 90% of the population, over 90% of the population needs to buy into that. We don't know how to do that, however, with democratic tools, with usual policies, unless we are authoritarian about it. In other words, make the vaccination obligatory. We don't know how to do it otherwise. And we don't know how to get 95% of the population involved. There are populists, there are obscurantists, there are scientists on the other side. If you want to accept a democracy, there are bound to be people who will not be in agreement. There are many professionals, as we were saying, including doctors, but especially nurses who are very reticent when it comes to vaccination. So there are professionals who are against it. So for some diseases, it's going to be difficult. We can see this for measles and for mumps. And we mustn't be exaggerated either. We talked about deaths from measles 5 years ago. There were 70 deaths in France alone, and nobody's shocked by that. So if you like, we've got tools or microscopes that are very different, or binoculars, if you like. We can accept that there be 6,000 deaths from flu, and every year there are at least on average 6,000 people who die. Not many people are shocked by that, but we've got a vaccine that's not efficient on elderly people, so we shouldn't give it to elderly people. That's a different problem. People aren't that stupid, after all. People have a good sense, and for polio, they can't really understand why. When there's a good vaccination coverage, why make it obligatory? Because there is no more polio. There were 10 cases last year across the world, so there's no risk that our children may contract polio unless they have humanitarian parents who go to Afghanistan. Now, I'm not saying that we shouldn't vaccinate against polio, but should it be completely obligatory? Should it be completely obligatory? I'm not sure. Maybe There are other vaccines that would be more advantageous, rotavirus, chicken pox. Maybe we need to work on the population more when it comes to those vaccines, because those diseases are important for public health. Okay, let's take a step back. Let's not move away from vaccination. And let's just say that we need to focus on public health. Philippe Juvin, you are a European Member of Parliament. So we've been talking about federalism. What does a French European Member of Parliament think? Well, health should be under the responsibility of countries. That's what some people say. And when it comes to vaccination, one of the challenges that we have is an epidemiological risks, Ebola, H1N1. We also share technological challenges with MBIC. We've got economic challenges with the free trade for products and professionals. Europe is supposed to guarantee well-being and health, but we can't say that we have the means to do this. We had different programs developed, 700 programs, but that doesn't give us an overall policy. And when it comes to financing for between 2014 and 2024, public actions at European scale, that large program over 6 years had 400 million euros. And that's not much when we consider that it's 200 billion euros in France that is spent every year for health. So we realize there's a really big gap. So what about buy-in to international standards? This seems paradoxical when we're talking about vaccination, because to prevent pathologies from being communicated, there are international standards in the European Union that say that populations have to be vaccinated against risks or emerging risks. When we talk about measles, there are clusters of measles in Northern Europe, in Spain and elsewhere. So not very many cases. This is, of course, terrible for people who die from measles, but we need to look at what might happen in 5 years' time or in 10 years' time or in 15 years' time in terms of the communication of such diseases. And when we look at the results of European policy when it comes to health, the results are not great. Inside the European Union, there's a gap of 13 years when it comes to life expectancy. So even people who use the same currency. So between a manager and a worker, there are differences. So child mortality, the differences are quite considerable. And what about mental health? The risk of dementia is doubling when people get to a certain age, 65 years of age. And whereas chronic diseases account for 700 billion euros a year in terms of expenditure on a yearly basis. And you can compare that to the GDP of states. I believe that we must stop talking about countries being responsible alone for their health. I think we often criticize Europe. We talk about its democratic failures. So I think it's important to have a European focus on health. This will bring people together. I had a battle in Parliament not long ago. I wanted to have something generalized in advertising, and I failed. I was told that there was a risk that Italy and Portugal would go to the European Commission and then onto the Council, then who would generalize this Nutri-Score in advertising. But then we could have been attacked from another point of view. But I don't want to hear that. It's a very destructive kind of message. I'm part of a party, En Marche, that is promoting a European approach. So it's hurtful to hear this kind of thing. Why do we repel these things that we could do in France? I think we have to stop having this kind of message. We have to stop with that. We have to focus on a common policy. And in terms of vaccination, if I may, scientific knowledge is not just an idea. Scientific knowledge is established. And when we know that vaccination allows us to eradicate pathologies, poliomyelitis, for example, is almost eradicated. All of the NGO programs have been stopped now for several years. Somalia, perhaps has a problem still, but we don't really know. So what about variola as well? This was eradicated too across the world. And yet, the last case was identified not long ago. Anyway, there are things that we can avoid. Vaccination, we need to have a courageous policy. I'm sorry about the decision of the Ministry for Health in Italy saying that vaccination has to be stopped. I'm delighted and very proud to have a health minister in France who has a courageous policy when it comes to vaccination that is obligatory. It's not easy to explain to French people, but the political debate is good. We've had very little feedback from people in the field who were not happy with that, whereas as it was quite a touchy subject. So HPV, this is under there is a collective responsibility. 800 young women who die of cancer those deaths can be avoided. And we can talk about vaccination for men as well, for young boys. You know, people are debating this in the profession, whereas it's not the case for measles. So if we vaccinate everybody against HPVs, we wouldn't have to have any more smear tests, and the problem would be solved. That's what some people say. But we can't consider that solves the problem. I think we must never abandon the fight. We always need to explain why it's important to have HPV vaccination. I talked about this with the Prime Minister and the Minister of Health. I don't want to bring this to the Parliament, but we can certainly do something about this. There is a specific stakeholder, a cross-border stakeholder in Europe, and that is the associative world, associations of patients, and the role of these associations has become institutionalized. We've got Michel Serrati and his association, for example. We know that there is awareness in the world of patients, not just in terms of how patients are being managed, but also in terms of policies. Tucker Anderson was talking about Euro 10, so it's this kind of problem. I'd like to know, so this is a stakeholder who is often critical, in other words, criticizes. If we didn't have these associations, we wouldn't have dealt with HIV in the same way or as quickly. It was a kind of a trigger, if you like. So do you believe that in your environments, do you believe that there's a European focus on this issue? In other words, support for the creation of public policies at European level from associations?
I think there is the patients and the associations are a very, very important stakeholder here. We had DG Santé has organized last year a big conference where all these stakeholders were together in order to move the issue forward, because as you say, there is awareness among the physicians, among the nurses, everybody involved in health and in this topic, that something has to be done. So what turned out there was a need for one source that gives independent, reliable, transparent and evidence-based information. A so-called European vaccine portal where patients can go when they hear any news, where also physicians can go. And that is what we are now creating. Hoping that it will serve really as a reference, as a checkpoint when there are news about. So that is one thing that we want to do, and that really emerged also when what is currently underway, council recommendations for increasing the vaccine coverage. Now that will be a very powerful tool. They're right now under deliberation on the council, but if this will be adopted, then it is really a commitment, a very strong commitment from member states to do something. The vaccine portal is, of course, in there. Now, the other tools that we have, we have collected them from all over the world, what has been done in various places to enhance vaccine coverage. And it's published as a catalogue of possible interventions on our website so that people can go there and see, don't have to reinvent the wheel. Because the mandatory vaccination was mentioned, and that's of course one of the tools. But very clearly, it doesn't work everywhere. We have countries in Europe that have high coverage without mandatory vaccination. So, and where the colleagues from these countries tell us, well, if we would have to put this mandatory, it would be absolutely counterproductive. So there is not, I mean, the reasons why people are not vaccinated is not because they're all against it. Some don't consider the disease serious. Some say, well, it's very difficult to get vaccinated. I don't have the time. And some belong to groups that are not reached by the so for these three, and then of course there are the ones, the hardcore, that are against vaccinations. But for the first three, it's really worthwhile to find out who they are and address them. And among those are really a lot of parents that have their first child. They want to do the best for their child, and then they read in social media, oh, it's dangerous to vaccinate and so forth. And then they look for someone where they can go to, and they go to healthcare professionals. And if they then have someone who is against vaccinations or doesn't know how to deal with these questions, we have a problem. So that is why we have also developed tools for training doctors how to deal with these questions.
Alors, je continue sur justement cette question.
Let me continue on this question of the healthcare professionals and the involvement of the healthcare professionals. We saw this yesterday with the young colleague who was trained in Romania. I was extremely disturbed by what he said about the welcome he received when he came back to France from the reception by his colleagues. What are we going to do with this migratory flow of colleagues who come from different countries in Europe, different training, different backgrounds that are not completely homogenized? Common tools, we don't necessarily have common tools. How do you see the evolution of a system to converge these different cultures and different professional training systems that have different curricula? Well, I've often used this European argument as the free circulation of healthcare professionals. 1/4 of the doctors in France have foreign diplomas already, so the numerous clauses just prevented French students from studying in France. This is clear. Now, once we've said this, can we have a demographic strategy in Europe for healthcare? Well, I think that won't happen tomorrow. First of all, because the systems are completely independent. Look at the English gatekeepers. The demography in England, I think, and Spain and Germany, if I remember correctly, there's a medical density of 0.7 per 1,000. It's considered as a high standard, whereas for us, it's a low standard, such as in a region like Franche-Comté. So thinking at the European scale and demographic terms is difficult. But however, I think we need to have this reflection. If I take the example of Fernando Pessoa, which was the Portuguese school, he said, we have a different type of diploma that we can offer on your national territory outside of the numerous clauses, outside of anything that you require in France, because through a convention with Portugal, we would offer the equivalent of a university diploma. Well, we blocked this partially. We know that it's complicated. The first graduates, the first dentists who've graduated have been registered as dentists, because we will need to think about this. We shouldn't stigmatize any country. I saw the young colleague yesterday who was trained in Romania. I have no problem with that. The problem I have is that we prevent young French people from studying medicine in France, and young physiotherapists go and fill the Belgian universities, and the Belgian universities had to set up quotas for foreign students because they had too many coming in. So the French students said, well, they took a job, for example, at McDonald's, and then they were considered as residents in Belgium so that they can continue their medical studies. So we see there's a considerable issue in terms of skills and training, and I think this could be a source of inspiration. I like to see what people are doing elsewhere. For the poverty plan, I looked at what Sweden is doing with the baby box that's given to the parents before the child is born. 95% of the couples request this. Can you imagine French couples requesting this. Even the box itself is intelligent because it's in the form of it avoids the risk of infant mortality because it's got a shape where the baby can sleep. So it's always interesting to look at what people are doing elsewhere in Europe. Now, the sources of European inspiration will concern societal questions with bioethics for MAP, medically assisted procreation. We've said, let's be realistic. It already exists in Spain and England and Belgium. 5,000 French women each year go outside our borders for an MAP elsewhere in Europe, and they pay for this, and it creates inequalities. So we've said we have to change our law in France. For euthanasia, we've said the same. We've compared a lot with what they're doing in Switzerland, the Netherlands, and Belgium. And so we always have a considerable source of inspiration by looking at our neighbors. But as soon as we talk about risk management or the organization of practice or professionals in training, all of a sudden, the inspiration disappears. Well, we're almost at the end of our debate. We have 3 minutes left. We could continue for a long time because it's so interesting. But I would just like to ask each one of you to give us one concrete measure that you would suggest so that our authorities, national authorities, would accept to give more power to Europe. If I've understood what our European Commissioner said earlier, this is exactly what we need. What can we do concretely in each country to ensure that we really move towards some baby steps in terms of public health at the European level?
The countries. I can only speak from our organization that works with all the countries. And what we are doing is we are trying to identify in the diversity those things that we can bring to give a certain standard to everyone. Because I think that diversity is part of Europe, united in diversity. And I think we should use it. Everybody can learn something from everybody else.
Antoine.
I think that we're lacking in Europe what exists in the U.S. called the U.S. Preventive Service Task Force. It also has an open website. You can go onto the website. They try to look at all of the medical prevention measures, and Europe could extend this to non-medical prevention measures for chemical or nuclear prevention measures as well. And this service is based on evidence. It really provides factual elements for prevention. People talk a lot about prevention in a very non-factual way. What are the real prevention measures that we are not applying today in France and in other European countries? We know that almost everywhere, screening colorectal cancer is not very well performed and not very well accepted, whereas the evidence is high that it's very useful. So how can we improve this? We can use this type of service or agency that doesn't exist at the European level. And I don't think we can do this in a single country because it requires a lot of experts, shared expertise, a shared culture, and probably also a lot of hard work to review the literature, the scientific literature that exists. There's no point in reinventing what the Americans already do very well. But when the Americans talk about weapons, this doesn't interest us. Well, they need more prevention, for example, in terms of weapons. That's not our problem, but we need a European prevention culture, and I think this is something that's still lacking. And I think we could really share and implement this fairly quickly. Well, there's so many things to say. What I'm afraid of is that if we consider that health is the poor relative of European policies, we give up. And I agree. I think there are two aspects. We can prevent avoidable risks. In Europe, this is where people drink the most alcohol and smoke the most cigarettes. And CHAM is at the rooftop of Europe one weekend a year. But at the European scale, we need to educate populations to help limit the risk of smoking and excessive alcohol consumption, which are the first cause of avoidable mortality in Europe. And if we want to have an integrated construction model, why not think about transforming a medtech or a biotech giant or a giant in e-health? When you look at China, I went to China this year look at what China is capable of developing and the US and Canada in terms of artificial intelligence, we won't be able to succeed alone. So this can be an entry point. And again, I'm convinced that this is a way to guarantee, to fight the deficit of democracy that we often accused Europe of. Well, we've reached the end of the roundtable. Thank you very much.